Welcome to America with an Accent. African Americans and Latinos are two minority groups that have suffered the most during this COVID-19 pandemic. Why is it so? What are the reasons? What does research show? And what is the next step? Also, will we have a vaccine by this fall? Here are the answers. Dr. Eliseo Perez-Table is the director of National Institute on Minority Health and Health Disparities in Bethesda, Maryland, and we reached Dr. Perez-Table in his home in Washington, D.C. Thank you, Dr. Perez-Table, for being on the program.
My pleasure to be here with you today. Thank you.
The current data shows that at least 2 out of 6 minority groups identified by NIH, namely African Americans and the Latinos, are paying the highest price in this pandemic. Do you agree with that assessment?
That is definitely what the data indicate. It's trickling in from different areas. I would say that it probably is expanded from Latinos and African Americans. There is clear evidence that the Navajo Nation is also been very affected by the COVID pandemic, and probably other American Indian tribal nations as well. We also have evidence that Native Hawaiians and Pacific Islanders from both the state of Hawaii and where they live in California and Utah have increased risk of mortality as well.
Okay. Are you surprised by these findings, by this data?
We should not be surprised given what we've learned about this virus, this novel coronavirus. I think initially we weren't anticipating this to be such a dramatic impact, but retrospectively we say, well, what else could we expect? There are at least 2 clear reasons why we think this is happening. One is the level of what we call comorbidities or coexisting conditions that increase risk of severity and death in COVID-19 are higher among all minority groups. So primarily we're talking about diabetes and obesity and cardiovascular disease to a large extent. These 3 conditions are more prevalent among Latinos, African Americans, and other minority groups, although the prevalence does vary. Second, the community lives in more crowded circumstances. So if mitigation and physical distancing, like we're doing now, works to some extent, and we're able to do it and keep working, many people in service-oriented jobs need to be out there or live in more crowded conditions. So they're public-facing. They're in transportation, they're working in the stores, they are doing deliveries, and they're more impacted by exposures, random exposures to community level transmission. Plus, they come back home, and perhaps in a space that we have 3 or 4 adults living, they would have 8 to 10. And that's how they manage with the cost of housing. So that's a second factor, more crowded, more likelihood of transmitting the virus. And I guess a third factor underlying all this is the structural disparities that have existed for a long time in the US, and that
Yes.
Impact of a catastrophe, such as we've seen with hurricanes in the past. Now with this pandemic, the impact is magnified by these structural disparities.
Okay. So before COVID-19, what were the acute problems in health in minority groups?
Each group is different, and within each group there are subpopulations that are often different. So it's hard to always generalize, but I will try my best to identify the ones that matter the most across the board. As I mentioned, excess weight, or really obesity, and especially morbid obesity, is more prevalent in all groups that we've discussed, except perhaps Asians generally. But some groups of Asians do have this problem as well. Diabetes is more prevalent in all minorities, including Asians. and that is a major contributor to chronic disease in this country. And then the leading causes of death and disability in the U.S. were, the main things that affect minority groups. So heart disease, uh, hypertension, heart failure, especially cancer, strokes, um, accidents, chronic lung disease, especially asthma in some populations. So these are the common things that everyone gets, and we see some variation and disproportionate effects in some groups.
Okay.
From our institute's perspective, many of the outcomes of health are influenced heavily by what we call social determinants of health.
Yes. Can you
Um,
please elaborate that a little bit more?
yes. So we start with race ethnicity as a social construct. That's the first thing. It brings a lot of history and other factors into it. Socioeconomic status, so most easily measured by years of education, and
Okay.
of course income or wealth, um, and then a variety of other constructs or concepts like health literacy, food security, housing security, the level of English proficiency for immigrants, and things at your occupation, your work, and the level of prestige you have in it. And then there are the behavioral risks that we know happen, such as cigarette smoking, physical activity, diet, that really, and then substance use that really influence many of these important outcomes. These are all laid over what we're calling structural determinants, structural social determinants. So this are there access to jobs in your community?
Okay.
Jobs that pay a living wage, as we like to say. Are the schools good? Do you have green space available if you live in an urban environment?
Okay.
Do you have transportation that you can take, although that may change after the pandemic, and how we think about that? Do you have access to a full service supermarket? I spent, just to put an anecdote into this, I spent 37 years living in San Francisco, which is, as we know, a high income community. The African American neighborhood also mixed with Latinos, called Bayview Hunters Point, to the day I left 5 years ago, did not have a full service supermarket in an area of Southeast San Francisco. So no, they had convenience stores, but no full service supermarket. So that's a structural inequity that the people living in that community have no control over, and that our system did not find a way to address that, although there were efforts to try and do that, and they may have been done since I left.
Okay.
That's an example.
Well, if I connect
So,
the dots
yeah.
here, social level determinants and factors, and what you mentioned before, the two reasons why we see minority groups impacted the most. The next question that I have, and it's something that you have touched in your last publication in the Journal of American Medical Association as well.
Mhm.
Did this standard approach of addressing coronavirus among minority groups really apply to minority groups? Was the social distancing and shelter at home approach effective in preventing the infection of the minority groups in the United States?
Right. Thank you again for bringing this up. I want to put it in the context of the novel virus pandemic, unprecedented. We just have not seen anything like this in our lifetime, and perhaps people date back to 100 years to anything that approximate this with the influenza pandemic of 1918. Be that as it may, mitigation or these physical distancing measures, shelter at home, does have an effect across the population by what public health leaders have called flattening the curve. It saves the healthcare system from collapsing. That's the first thing it does. A hospital can be easily overwhelmed with many sick patients needing to be ventilated or supported for their breathing. And this would be a major crisis for our healthcare system.
Okay.
Wuhan, Milan, and New York, to put examples, sort of came close to that crisis, but were able to avoid it. The rest of the parts of the U.S. for sure have not experienced that level of crisis.
Okay.
So mitigation works at that level, but it doesn't stop transmission of the virus. We've seen a fairly steady number of new cases in most communities, even if there hasn't been a surge. Um, and one would expect that if you live in a crowded home, that you are less likely to be able to isolate. Let's say if you live in a household with 8 people and one person is exposed to a case because he or she works as a nurse in a hospital or in a clinic, that person will find it very difficult to isolate because they don't have the means to go to a hotel. They don't have a second home to go to.
Exactly.
They live in less space, so they're bound to potentially expose everyone who lives in that household, even if they just sheltered at home.
Yes.
So the challenges are multiplied in minority communities and in poor communities of all colors because of these factors. The next step of
Exactly.
addressing this pandemic, other than the goal of course, the great vaccine and effective treatments, which we're working on at NIH and across the world, is what I think is it depends on testing and contact tracing. So again, going back to proven methods in infectious disease control. So we identify a case, a clinical case, then you're able to trace back 2 to 3 days everyone who's been in contact with that person, test everybody who that person has been in contact with, so that we can try and isolate that focus before the transmission chain gets propagated. Every case of coronavirus, novel coronavirus, the COVID-19, infects at least 2 people, and that will not end the pandemic. In some early reports, it was 5 people. We need to get that number below 1. It's called the R naught or the R zero. We
So,
have to get that below 1 in order to begin to see the pandemic, the new case rates go down.
okay. So you're suggesting that the next step would be to increase the number of people tested
Correct.
for the virus. Is that real achievable? Is that step achievable?
It is if we focus resources and effort, but it's not just testing, it's
Okay.
testing and contact tracing. So we
Okay.
have to know when you identify a case, who that person has been in contact with, and then I try and contain that focus of infection, so that everyone who is around, who was in contact with that person who is infected, gets tested quickly, and so we know how many people have had this transmission.
But
Uh, when there's massive amounts of cases, that doesn't work. If we Now that we have blunted that and see some steady state, that would be, in my perspective, and I think the general consensus, the next thing to do. When could we do it? I think we're looking at implementing all of this and doing as much as we can, or showing that it can work, even in a research context, before the beginning of the new flu season in the fall.
in the fall.
And we hope to have a vaccine trial in the field, and hopefully have vaccine available certainly within a year. But we have to get lucky to get the right vaccine out. Yeah.
But I would like to go back to what you said about the testing. We are all hearing about the shortage of testing options here. Uh,
Correct.
that's why I asked you, is it a wishful thinking, or it's really a doable step, this increase or testing not only the person who has been identified, but also people that have been in contact with that person.
Correct. Yeah, it is achievable if we all work hard and put enough resources. Although it is an aspirational goal, but I think it is achievable. Let me put some numbers on it.
Exactly.
There are about 300,000 tests being done on a daily basis in the U.S. right now. We need to get to probably about 1 million per day in order to begin to work on this. Because the country is so large and the pandemic has affected different areas differently, it is feasible, I think, to focus on some areas and demonstrate that this strategy can work. Um, NIH is working hard with private industry and FDA to advance the development of point of care testing. So the current testing requires, a deep swab into your nasal passages, goes to a big box laboratory at least a day before the results are back. We're looking to have technology, not at my institute, but another institute,
Okay.
developed that will be point of care, um, results ready in an hour or within an hour, that can be then disseminated much more broadly
Okay.
and easier to administer, not just for disadvantaged populations, but for everyone. And I think this is a goal. And can we do it? I think it's feasible. It's a challenge, though,
Oh,
and the Congress has provided funds for NIH to work on this, and my colleagues are very much concentrated on doing this.
okay.
Our institute and others will be working on the plan of how do we get tests to our communities who are suffering the most from the pandemic.
Okay.
So that's the plan that our institute has. Remember, NIH gets the funds to give to grantees, give grants or for companies and scientists out there to actually, and engineers actually, this is mostly an engineering issue, and the scientists to work together to develop this.
Okay.
Internally, we do work on some of these issues, but most of this is funds that we get the best minds in the country to work on the problems that we identify. If we can show in a research context how this can work, then the policy makers can implement this more broadly with more resources than what NIH is receiving for this.
Okay. Is there data available on how many minority members of minority groups have contracted the virus, and how many has lost their lives to this virus?
I have not seen national data. I don't think that we have that yet. Attention to collecting race ethnicity only came into light about 3 weeks ago. Some of it is systems are stressed, taking care of sick patients. They were not completing all the forms. Normally, they have time to do this.
Okay.
We've seen as high as 80% of hospitalized patients in Georgia, 16% of deaths in Connecticut when the population is 10%. In New Orleans, there were 70% of cases were African Americans. In the District of Columbia, we can see variation by ward. So the wards, the areas of the district that are higher proportion African American have more cases.
Okay.
But we don't have a handle yet on a clear-cut number. In New York City, Latino Hispanics were also had higher rates of infection.
Okay.
So I would be remiss to also not say something else. The pandemic has led, and the mitigation efforts have led to an unprecedented surge of unemployment. Everyone's worried about the economy. More people are worried about the economy. And these 33 million people that have been laid off, hopefully many of them will get their job back, but many won't. Many have insurance, health insurance linked to their job. This has disproportionately affected Latinos and Blacks. We know that already. So the unemployment rates have surged for everyone, but are much higher for Hispanics and for African Americans. I'm assuming that under those intense pressures, doctors were completing the form. They had gender, they had age, they had severity, but not the details. And we've seen this happen before. It happened with the HIV epidemic in the early 80s as well.
I understand that, the first step that you're considering at this point is that point of care device that will make it possible and easy for many people to be tested. But in the long run, let's say we're lucky and we have a vaccine, but maybe we're not lucky by fall and we don't have a vaccine in place. How will we address the situation? Again, how will you ask people to, or minority groups that have suffered so much social distancing? Is that, are we wishfully thinking here? Because I just don't see how in 6 months we can change their living conditions or working conditions for that matter.
No, your point is really important. We have seen what can happen. We should anticipate that we will face something similar in the fall. A vaccine will not be ready by the fall, and we may have some therapeutics for the severely ill, so we won't see as many deaths or as many people in the intensive care unit. That's possible. I think that is possible by the fall. But our lives are changed, and I don't see us going back to mass gatherings for cultural events. I think we have to rethink how we have thought about mass transportation until we have more guarantees of safety. And wearing a mask helps primarily because if you have the virus and you're not aware of it, or you're asymptomatic, which happens in at least maybe 20% of the time, or very mild symptoms, you decrease, or not eliminate, but really decrease the likelihood that you'll infect someone else. But the common masks that we all wear, cloth or surgical, are not going to protect you from potentially being infected if someone is in close proximity to you. So, I'm sorry?
What can we do in this situation? We're talking about public housing here. We're talking about working conditions when people are working next to each other. Can we really change those things in 6 months or before the winter hits?
I don't know. I think that we have to see what happens. We have to adapt. Clearly, the U.S. government has been concerned and provided these support cash-wise to families under a certain level of income, and also small businesses. Some economic activity will reactivate, but in the balance, if we are seeing a situation like we saw in New York City in the month of the end of March and early April, it's very difficult to continue to have normal economic activity when people are being infected and dying. So there has to be some sort of a balance struck. We're not going to eliminate the virus, and we're not going to go back to normal, quote unquote, the way things were a year ago in terms of our society, until we have a better understanding of how we can manage and control this. I think it's doable, but it's not going to happen in 6 months. And a combination of interventions will I think lead us to a manageable situation, but I don't think anyone really knows exactly what that is going to be right now.
So we are in the unknown area when it comes to strategies and plans for the future at this point?
We have many potential strategies, many potential plans. I do feel that the best scientific minds, counting our planners, engineers, policymakers, are working on this 24/7. I don't think anyone has, okay, here's the plan that we need to do for sure. I expect that as the next few weeks, we will have more clarity on what the next steps are.
Before I let you go, Dr. Perez, I have one question. You said that very clearly that we will not have a vaccine by fall. Why are you so sure?
I am reflecting what I've heard my colleague and Dr. Anthony Fauci say. Scientifically, there are 3 or 4 good vaccine candidates that will need to be tested for first safety, and I think at least 2 of them have already gone through that. Then a trial in a smaller number of people just to see if you can get some immunological response that would explain why you would get immunity. And then the larger efficacy trials, or does the vaccine protect, will probably happen, if best case scenario, in the fall. So to then say, okay, the vaccine looks promising, let's get production going up, and the private sector has agreed to do that without knowing for sure that this is the right vaccine. It takes time to go from, we've got the right vaccine, let's mass produce 1 billion doses. It takes time to do that. So I think the best hope is beginning of calendar 21. There will be a promising vaccine that we can start giving out. That's the best hope I see right now. But I would not be shocked if we had some delays in that. So
thank you, Dr. Perez, for being on the program.
Thank you for having me. It's wonderful to talk to you, and I hope to keep getting the message out.
All right. Thank you.